I'm going to talk to you about the fragility index. I'll also just introduce this by talking a bit about p-values and confidence intervals as a backdrop to this issue. So the goals of the lecture are discuss p-values and discuss what they actually are telling us, inform the interpretation of confidence intervals, and offer some insights into what is the fragility index and whether or not this might be of value as you look at literature. So the p-value represents the probability of a result occurring due to chance. So that's what a p-value is informing you of. A p-value of 0.05, if we were to repeat an experiment 100 times, we'd expect to see that result by chance alone 5 times in 100. A type 1 error is when we assume that there is a treatment effect when in fact there is not a treatment effect. And the probability of making this error is referred to as an alpha level, and by convention this is set in clinical research at a value of 0.05, corresponding to a p-value of 0.05. So in other words, when we accept that our threshold is going to be an alpha value of 0.05, if in fact something is just below that, then if let's say it was 0.049, we are accepting that by chance alone, we may see that result essentially about 5 times in 100, and it's not due to a real effect, it's a chance phenomena. What most people have encouraged is to switch away from p-values and to use confidence intervals. And confidence intervals represent the range within which the true result may exist. Now you can do confidence intervals of various ranges. The most common one that is used is the 95% confidence limit, and this is by convention to also correspond with the p-value threshold that is most commonly used of an alpha of 0.05. Assuming no bias, if we have a 95% confidence limit, we can expect that the true effect exists within that 95% of the time. The advantage of a p-value over p-values when we use confidence intervals is that they not only convey the probability of chance, so they're informing this issue of the alpha of 0.05, but it also conveys information on the true treatment effects that can inform whether or not there is also clinical significance and not simply statistical significance. So we may have something that is statistically significant that we believe it's improbable that it's due to chance alone, but the treatment effect may be small enough that we actually aren't that interested in it given the actual side effects or the costs or the inconvenience of the intervention. P-values tell you nothing about that, but 95% confidence limits allow you to be informed about that information. I now want to present to you 2 hypothetical cases. And in these hypothetical cases, we're going to be evaluating a new treatment for the prevention of myocardial infarction. Now, these 2 trials will be set up identically, so everything about these trials is identical except for one thing that I will show you in a moment. These will both be placebo-controlled trials, and the outcome will be myocardial infarction. Everything that we think matters to prevent bias, that is systematic deviations from the truth, is done correctly. So we think that this is a very low risk of bias in this trial. So it's a concealed randomized control trial. There's blinding of patients, healthcare providers, data collectors, outcome adjudicators. The follow-up is complete. It follows an intention to treat analysis. The trial is not stopped early, and everything we think matters is done right. So in general, most people, and certainly evidence-based medicine has taught people that there's 2 factors that matter. One is systematic deviations from the truth, bias, and one is the issue of chance. So in these two trials I'm going to show you, I want you to assume the exact same level of bias, and it's very low. So that is, we think there's not an explanation of systematic deviation from the truth. And then the only issue that we really come back to is what about chance? So in the first randomized control trial, we're going to randomize 100 patients to receive our new investigational drug A. And amongst these 100 patients, one of these patients will suffer a myocardial infarction. We'll also at the same time randomize 100 patients to receive a placebo, and 9 of these patients will in fact suffer a myocardial infarction. The p-value is 0.05, which is below our conventional level of significance. So most people seeing this result would in fact assume that low risk of bias trial, p-value below 0.05, making it less credible it's a chance finding, this is most likely a true finding of a treatment effect. The second trial that once again uses the exact same high-quality methodology In this trial, we randomized 8,000 patients to receive or participate in this trial. 4,000 will receive our treatment B, our investigational drug B, and amongst those patients, 200 will suffer a myocardial infarction. And in 4,000 will be randomized to a placebo, of which 250 will suffer a myocardial infarction. The p-value for this trial is the exact same as the first trial. It is 0.02. So once again, this suggests in a low-risk bias trial, so highly valid trial, that we have a result that is not likely explainable by chance. The p-value suggests this is a real finding. So now what I want you folks to do is you're going to vote in 1 second. So the way you're going to vote is, what I want to know is what best characterizes your belief in whether there is a real treatment effect for treatment A and treatment B. Now, it doesn't mean that the point estimate of the effect is what matters, just that, yes, treatment A works or treatment B also works. If you think it's similar for both trials, it's going to be 1 as a response, and I'll actually show hands in 1 second. If you think it's substantially more likely for treatment A, then you'll put up your hand. If it's going to be modestly more likely for treatment A, and then the fourth option will be substantially more likely for treatment B, and the fifth option will be substantially or modestly more likely for treatment B. Once again, treatment A was our first trial, 9 deaths versus 1 death, p-value 0.05, 200 patients, and treatment B is when we had 4,000 patients versus 4,000 patients, and 200 deaths versus 250, and a p-value of 0.02. So, show of hands, who thinks that the best characterizes your belief in whether or not there's a real effect of treatment A and B? Do you think it's similar for both groups? Show your hands. So I see a few hands, very few though. Who thinks that it's substantially more likely for treatment A? A couple of hands. Who thinks it's substantially more likely, modestly more likely for treatment A? Few hands. Who thinks it's substantially more likely for treatment B? Much larger group of hands. And who thinks it's modestly more likely for treatment B? And there's a few hands there. So what's interesting is that at one level, you're contradicting what is a tenet of evidence-based medicine, which is if I tell you the two trials have the exact same methodology and that they're very low risk of bias, and the only other issue that we're typically looking at is chance, and I told you based on p-values, the chance looks the same between these trials. Despite that, there's actually differences in our opinions about whether or not there's a real effect for treatment A and treatment B. So let's go on. Another way of looking at these two trials, same two trials. So once again, in our first trial, 100 patients received treatment A. One of those patients has a myocardial infarction. And the placebo, 100 patients receive it and 9 have a myocardial infarction. Another way to look at this result is what is the relative risk reduction and the 95% confidence limit. So the relative risk reduction is 90%. And the 95% confidence boundary around that treatment effect goes from a low value of a 23% relative risk reduction to a high value of 100% relative risk reduction. The second trial, which randomized once again 4,000 patients to treatment B, 4,000 to placebo, 200 versus 250 myocardial infarctions, the relative risk reduction, the point estimate effect is 20. The 20 is below the lower boundary of the first trial. So the point estimate is actually lower than the lower boundary of the first trial. And the 95% confidence limit goes from a low value of 5 to a high value of 37. So the question is now, based upon seeing this additional information, and once again, we're just informing the question of what best characterizes your belief in whether or not there's a treatment effect. Not the point estimate effect, but there is an effect. Who now thinks it's similar for both trials? So no one is voting for similar. Who thinks it's substantially more likely for treatment A now? Who thinks it's substantially more or modestly more likely for treatment A? Who thinks that it's substantially more likely for treatment B? Still a few hands. And who thinks that it's modestly more likely for treatment B? Okay, so I've clearly left a lot of people completely confused because no one knows how to vote anymore. Okay, well, I can understand that, and I can understand that you might be feeling like, well, I thought more people starting this felt that, hey, treatment B, it makes more sense that that's likely where there's a real effect. And then when I show you the relative risk reduction, their 95% confidence limits, I'm assuming by the fact that most people voted, they no longer felt confident about that anymore. I put forward to you that small variations in clinical trial results at times can have a big effect. And what if we actually changed the results and we added, instead of 2 of the events in the treatment group being no outcome, what if a sudden they became a myocardial infarction? What do you think would happen to the p-values? So in other words, in the first trial where we were looking at 1 versus 9 myocardial infarctions, what do you think the result would have been if it had been 3 versus 9 myocardial infarctions? What do you think would have happened to that p-value? Do people think it would have went above 0.05? Show of hands, who thinks it would have went above 0.05? Okay, who thinks it wouldn't have gone above 0.05? Okay, so most of you still think it won't go above 0.05. Okay, it will. So if in fact we made it 3 versus 9 events, the p-value would be 0.13. The second trial, it would have no effect on the p-value. It would affect the p-value 2 decimal places to the right of the 0.02. So it has no meaningful effect, because in the second trial, we'd be going from 200 versus 250 myocardial infarctions to 202 versus 250 myocardial infarctions, and it has no meaningful impact at the second decimal place for that p-value. So small variations in results for the first trial can have a big effect on the actual p-value, because if I showed you the first result with a p-value of 0.13, no one would be likely thinking, hey, there's a treatment effect here, yet a small change in the number of events had a real impact on what happened to that p-value. From this, we can think about conceptually a fragility index. And a fragility index is the minimum number of patients required to switch from a non-event to an event in one of the groups to reverse statistical significance. In the first trial that I showed you of 9 versus 1 myocardial infarctions, if we just made a change of 1 patient, so in other words, it became 2 versus 9 myocardial infarctions, that result would no longer be statistically significant. So the fragility index is a difference of 1, so it's 1. In the second trial, we would have to add 9 events to the treatment group, so it would have to go from 200 myocardial infarctions up to 209 in order to reverse statistical significance. Now, similar to p-values, there is no magical number about what is a threshold we should use for fragility indices. In the same way that we've, by convention, been using 0.05 for what is statistically significant, that was not chiseled by any ancient sort of civilization that said always use 0.05. There's nothing magical about that. We just have accepted that in convention. With the fragility index, I'm not sure what is the right value, but what I can tell you is this. From doing clinical trials, if your result is hinging on a difference of 1, 2, or 3 people showing up in one group or not showing up in one group as an event, you should be very cautious about those results. There is a lot of things that happen in trials that have nothing to do with the treatment effects that actually could influence whether or not people do or don't show up with an event in the treatment groups. So if I now show you all of the information about the trials, including the fragility index, I hope that most people would now move towards feeling that, in fact, despite the fact that the 95%, the p-value suggests that these 2 trials were the same, the 95% confidence, if anything, suggested the first trial was more believable. But hopefully when you see the fragility index, you actually feel a lot more cautious about the first trial, although it may be a real effect. I think there's a lot of reasons why we should be cautious about it, whereas the second trial is so much more believable because the fragility index is so much higher. We'd have to add a whole lot more events to that treatment group in order to reverse statistical significance. So the fragility of trial results. Highly cited studies in leading medical journals. So this is a study that was published in JAMA. They took leading publications that had highly significant results in the New England Journal of Medicine, Lancet, JAMA, and I think the Annals of Internal Medicine. When they followed those interventions over time, 16% of the time, those results in that trial that was highly influential and highly referenced will be subsequently contradicted. And another 16% of the time, the treatment effect was at least shown to be substantially exaggerated. It wasn't as big a treatment effect as what people thought. The only identifiable factor that explained this difference was that it was the initial trials that actually showed that were commonly overturned and exaggerated result had few patients and few events. Now, one thing I would encourage you to think about, so for all of the talks you'll hear today on randomized controlled trials, I think there's essentially one principle, and if you remember this principle, and you think about how this principle applies to whatever issue you're discussing in your randomized controlled trial, it will invariably inform you about what is probably the right thing to do. And the issue is, what is the goal of randomization? And the goal of randomization is to achieve balance of prognosis between the two groups. Everything that we do that distorts that balance of prognosis, if you can avoid it, you will in fact enhance the validity of that trial. And that is the underlying goal of what we're doing in randomization. Now, in our zeal to turn people onto randomization, I think, though, we've also not told a complete story about it. And I put forward to you that the issue of achieving balance of prognosis is not simply achieved by randomizing just 2 patients. I put forward to you that you have to randomize a lot of patients. So if you think about our topic that we were discussing of myocardial infarction, research shows that there are 9 independent risk factors associated with myocardial infarction. The prevalence of these risk factors in most trials that are looking at trying to prevent myocardial infarctions range from about 18 to 65%. That's every one of those risk factors. These risk factors actually often have substantially larger associations with myocardial infarction than the actual treatment effects with our drugs that we're actually evaluating. So as an example, smokers have an odds ratio of 2.87, which is much higher than all of our treatment effects that we explore with drugs. It is not difficult to understand how the effect in the first trial that we did of 100 versus 100 patients, when we think about 9 risk factors that are associated with MI, how we're not likely to get perfect balance of that. Also recognize risk factors are associated with each other. So if in fact I am a hypertensive patient, there's also a higher likelihood that I could actually have diabetes. And when we have small numbers of patients and you only have a fragility index of 1, in other words, I only needed 1 patient who is absolutely destined to have an outcome to differentially landed in one of those 2 groups, then it's not difficult to understand how we might have distorted that result but had nothing to do with the treatment effect. Whereas when you think about the second trial, we've randomized now 4,000 patients versus 4,000 patients, the likelihood of a meaningful imbalance in those prognoses becomes way less. Now, there's been lots of research done on this. We just published a paper very recently. In that paper, we were suggesting that until you get past 1,000 patients, you're very susceptible to actually having potentially important imbalances in prognostic factors that, in fact, could be explaining the treatment effects that are observed. It can vary depending on the associations you're looking at, but in general, probably 1,000 patients is where we should be thinking about for a lot of the disorders that we treat. So background of the fragility index is that where this comes from is that there was a trial in the area that Gordon mentioned that I spend most of my time working on, which is in the area of preventing cardiovascular events around the time of surgery. There was a trial undertaken that was published in the New England Journal of Medicine. This trial randomized 112 patients. And in this trial, they were randomized to a beta blocker or it was control. It was not a blinded randomized control trial. There was 11 deaths in this trial. 2 occurred in the beta blocker group, 9 occurred in the control group, and the p-value was 0.02. So suggesting a very big reduction in death when patients received a beta blocker and had non-cardiac surgery. Gordon, Victor, myself, and many other people around the world undertook a trial that was called the POISE trial. And in this trial, we randomized 8,351 patients. And in this trial, there was 226 deaths. But in this trial, 129 people died who had a beta blocker, whereas only 97 died who had placebo. The p-value was 0.03. It's when I looked at these 2 trials at the end of the trial, it said to me, I think there's something that we're missing in the way that we're evaluating and thinking about clinical research at the moment, where we really focus on systematic deviations from the truth bias and then the issue of chance, non-systematic deviations from the truth. Because looking at these 2 trials, you'd say, well, from a statistical point of view, they're giving us essentially the same result, but it's in the opposite direction. And it doesn't make any sense that that actually is the case. But when I then started experimenting with creating the fragility index, I realized that this trial had a very small fragility index that made it much more susceptible to a chance finding, and that's where the fragility index was born. Mike Walsh, who is a very bright nephrologist who did his PhD with me, at the time of doing his PhD, he led some work on the fragility index, and this is work that we published in the Journal of Clinical Epidemiology. And in this study, we took just under 400 randomized controlled trials published in high-impact journals, and the trials had a statistically significant result. The median sample size was 682 patients. It ranged from a low of 15 patients to a high of over 112,000 patients randomized. The median number of events was 112, but it ranged from 8 to over 5,000 events. And the 53 reported a p-value less than 0.01. The median fragility index was 8, and it ranged from 0 to 109. 25% of the trials had a fragility index less than or equal to 3. And once again, this is the value we're using. I'm not telling you that it's absolutely true, but I'm just saying if it is 3 or less, from my experience doing trials, you might want to be cautious about the confidence you have in that result. Moreover, the fragility index was less than the number of patients lost to follow-up in 53% of the trials. So in conclusion, in our zeal to turn people on to randomized controlled trials, we may have resulted in overconfidence in a lot of our trials. We need large randomized controlled trials with lots of events, but we need large numbers of patients randomized to get balance of prognosis, so hence we can then come back to believing differences that we see are not due to chance. We have significant results if in fact we have unbiased methodology. Positive trial results frequently hinge on few events, and the fragility index may improve trial interpretation and how we think about clinical practice. Thank you very much.